talk. So please let us, let me just start to take the topic, pharmacology of the antiplatelets. So, am I still audible?
Yeah, we can hear you clearly.
Okay,
But
so
you are
under
not
the
on
following
slideshow.
outline. So, as a way
Good.
of introduction,
Oh,
is it on
yes,
slideshow now?
yes.
All right. So, as a way of introduction, as we all know, in healthy vasculature, the platelets are maintained in inactive states. And this is possible by the substances that are released by the endothelial cells, the nitric oxide and the prostacyclin. So they are not active in active state. So platelets activation actually came about when there's a damage to the vessel wall. And that's as a result of the release of the damage, and that will cause the platelet to attach to the collagen via their glycoprotein 2B3 receptor. So the recruitment and the attachment of platelets actually happen in diseased endothelium. So when they are there, they undergo changes in shape and secrete some substances, including tryptophan A2 and ADP. And these substances actually work to recruit more platelets because ADP and tryptophan A2 are active recruiter of platelets. So recruit more platelets and cause a thrombus formation to actually seal the site of injury. So this is just showing what happens, what I've just explained now, that when there is damage to the endothelium, there is room for the platelet to attach to that because of their attachment of the glycoprotein 2B3A to the collagen of the vessel, and that causes release of A2 and ADP. And this is very important because the medication I'm going to be describing actually work to block each of these pathways. So the glucosamine pathway, the ADP pathway, and the glycoprotein 2B3 pathway. So platelets provide the initial hemostatic block at the site of vascular injury, and they participate in pathological thrombosis that leads to various conditions like myocardial infarction, stroke, peripheral vascular thrombosis. Now, talking about the drugs, medications one after the other, the aspirin, which is the earliest one, very been there for a long time, very cheap, and is the most widely used antiplatelet agent worldwide. Very cheap and effective, and it serves as the foundation for most of the antiplatelets. You know that even our commonly used dual antiplatelet that we give to our patient that has ACS has the aspirin as the backbone. So is the most commonly used antiplatelet worldwide. And it acts by irreversibly acetylating and inhibiting platelets cyclophosphamide 1. So that is mechanism of action. And that enzyme is critical in the synthesis of tryptophan A2. So, and as I've said earlier, tryptophan A2 is a potent inducer of platelet angulation. By blocking that tryptophan A2, aspirin actually works to reduce or prevent platelet aggregation. And it's important to know that the action of aspirin on the cyclophosphamide enzyme is permanent and is there for the lifetime of the platelet, 7 to 10 days. It's very important in secondary prevention in patients with established coronary, cerebrovascular, and patient with established coronary, cerebrovascular, and peripheral disease. And a lot of studies have been done with the use of aspirin And this one is the ISIS-2 study, the second international study on infant survival. And the trial shows that there's a reduced risk of infarction, stroke in patients that were placed on aspirin, and continuation even after the first month double the benefit by preventing further death and reinfarction. So it's not that it's not you should know that it's not recommended for primary prevention unless there's a clinical indication for the use of aspirin in primary prevention. So those clinical indications include when there is cardiovascular risk of at least 1% per year or 10% at 10 years. That's only indication where we can use as primary prevention. And also patients older than 40 years with 2 or more major risk factors for cardiovascular disease, or more than 45 years in men, or 55 years in women with one of such risk factors. The effect of aspirin is equal in men and women. It just depends on what we are using it for. For acute coronary syndrome, we want to go for high doses, high loading dose, after which you have to taper down to a lower doses. So, and there's no evidence of increased efficacy with higher doses. In fact, some studies have shown that the higher dose can even reduce the antiplatelets activity, because we know that aspirin can actually be used for other function, analgesic. So the dose that's reduced dose is actually important for its antiplatelets activity. So common side effect is GI, gastrointestinal, and it's dose dependent. And by the time you use a low dose, you are sure that you are able to avoid such complication. And rapid platelet inhibition requires an initial dose of non-enteric coated aspirin on at least 160 milligrams per day. So it's also important to note that use of enteric coated aspirin does not eliminate the risk of the GI side effects. Major bleeding is usually very rare, just when there is a concomitant use of other antiplatelets as a way of the dual antiplatelets, or when you are using anticoagulant in addition. And in those situations, as we'll be discussing earlier, it is best to use a very low dose when you want to use another antiplatelet to join aspirin, or you are using anticoagulants in addition. So it's shown that use of PPI and H. pylori eradication have been shown to reduce the incidence of GI bleeds in patients with aspirin. And also those that has aspirin allergy, characterized by bronchospasm, should not receive aspirin. And there's a triad called the SAMTAS triad. Consists
Seriously,
of
I'm
nasal
seeing your
polyp.
phone.
Hello, am I still audible?
Hey, you are not serious.
Am I audible?
Yes, we can hear you.
Okay. So SAMTAS triad, which consists of nasal polyps, chronic rhinitis, and aspirin sensitivity. So in those kind of patients, you want to avoid use of aspirin, and in those instances, opioid can be used. So overdose of aspirin is associated with hepatic and renal toxicity. There's also an entity called the aspirin resistance, which is defined as inability to inhibit thrombosin A2 synthesis, even when you are using aspirin. And the mechanisms that have been proposed for this include adherence or delayed absorption. By giving a patient with ACS aspirin, you want to say that you should chew it so as to enhance absorption. Now, moving on to the other group of antiplatelets, the pyridines, which are the P2Y12 inhibitors, which are actually linked to the ADP receptors. As I said earlier, ADP, its production from the platelet actually cause recruitment of more platelets. And blocking these ADP receptors will work to actually prevent platelet activation. So this one also acts reversibly, the same way with aspirin. So they're also irreversible blocker of the P2Y12 inhibitor. And most of them are prodrugs, and by that, it means that they need an metabolic activation to the active form. That is done by the system. So most of them have a prolonged action, and when the patient is on them and you want to do so, you want to stop them about 5 days, 5 to 7 days before surgery. So they are G protein coupled receptor, particularly GI, G inhibitory, and their maximum platelet aggregation is not seen until 8 to 11 days after starting therapy. And in some studies, a loading dose of up to 500 milligrams have been given to achieve a more rapid onset of action. So they need to be given with the loading dose to achieve a faster onset of action. So the clopidine is the earliest one. The ADP receptors are actually in different generations. The earliest one is, which is actually the first generation of the clopidine, the first generation ADP receptors. So the visual dose is 250 milligrams daily, and its inhibition of platelet persists for a few days, even after the drug is stopped. And a lot of studies have been done on the clopidine and have been shown to reduce cardiac events in patients with unstable angina, cerebrovascular events, are also in patient of stroke. It's as good as aspirin in that effect. The STAMI trial compares aspirin and clopidine given to patients after an acute MI, and it showed that there was no difference in the efficacy, the primary endpoint of death, recurrent acute myocardial infarction, stroke, and angina in the two groups that either receive the clopidine and aspirin. So you can say it's as effective as aspirin. And combination two have been shown to have additive and synergistic effects, and very low frequency of stent thrombosis when they are given together as dual antiplatelets. So a lot of the studies have shown that synergistic effect of aspirin and the clopidine, and it's better than monotherapy. Side effects include nausea and vomiting. Most serious is neutropenia. And in fact, it's one of the reasons why newer generations antiplatelets are developed to counteract those side effects, neutropenia, drop in platelet count, and because of that, you may need to be monitoring platelet count and white blood cell. And also, very rarely, thrombotic thrombocytopenic purpura have been reported with the use of the clopidine. So, talking about the second generation ADP receptor blocker, clopidogrel, very closely related to the clopidine, and as I said earlier, has a more favorable profile in terms of those side effects compared with the clopidine, and it's a little more effective than aspirin, though it's more expensive. And most of the time, it's been combined with aspirin in various studies as a dual antiplatelet medication. And when it's compared with aspirin, it has been found to reduce incidence of ischemic stroke, MI, um, peripheral arterial disease, and also global reduction of cardiovascular death, infarction, and stroke. Like 8.something. So a lot of studies have been done on clopidogrel from the PCI cure study, which shows a long-term administration of clopidogrel after PCI was associated with a low rate of cardiovascular death, myocardial infarction, or any revascularization of cardiovascular death or myocardial infarction. The PCI clarity study is another study. PCI clarity is clopidogrel as an adjunctive perfusion therapy, and also PCI cure PCI, clopidogrel in unstable angina to prevent recurrent events. Then Credo, clopidogrel for reduction of events during observation. In all of these studies, they show that treatment with clopidogrel significantly reduce the risk of retarded cardiovascular mortality or myocardial infarction in population that use both agents, either for stemming or end stemming. The third generation ADP receptor Pasugrel is more effective than the clopidogrel, though more expensive, and acts more rapidly and more predictable than clopidogrel. And a lot of studies are also being done on Pasugrel. The treating TIMI-38 study, they try to assess the improvement of therapeutic outcomes, optimizing platelet inhibition and Pasugrel thrombolysis in myocardial infarction. Compares Pasugrel and clopidogrel in about 10,008 patients, ACS, who were undergo PCI. It's of note that it's important to note that, as we mentioned earlier, when you want to use Pasugrel, you have to be able to have defined the patient coronary anatomy, and you are sure that you want to do PCI for the patient before you can give Pasugrel. Pasugrel is not given for a patient that you have not defined his coronary anatomy, and is not given for patients that you want to do medical treatment for. It's important to note that I will say emphasize that as I progress in the presentation. So in that study, the incidence of primary efficacy endpoints with a composite of cardiovascular death, MI, and stroke was lower with Pasugrel compared with clopidogrel. Then even stent thrombosis was also lower, but at the expense of higher rates of bleeding. And that's why it's have to be used when there's a clear indication for it. There are some contraindications for this of Pasugrel, which we have to know. And in those studies, there's some set of patients that actually have more toxicity or more adverse events with use of Pasugrel. And those patients include patients that are more than 75 years, or patient that has previous history of stroke or TIA, those that are less than 60 kilograms, those that have a renal impairment. All these set of patients, we have to, the actually contraindication to use of Pasugrel. The dosage is 60 milligram loading dose, then 10 milligram daily. Ticagrelor is an example of a fourth generation ADP blocker. It has its different class, cyclopentyl triazolopyrimidine. It is direct, oral, and compared with the three I've mentioned earlier, ticagrelor is reversible as compared with Pasugrel, clopidogrel that are not reversible. So it's a reversible P2Y12 inhibitor. And it's different from the other thienopyridines because it's not a product. It doesn't require any metabolic activation before it starts working. So it has a more rapid onset and offset of action than clopidogrel and produces predictable inhibition of ADP-induced platelet aggregation than clopidogrel. The loading dose is 80 milligrams per day, followed by 90 milligrams, and there is no need for dose adjustment in patient renal impairment. What should be put in place in those with hepatic disease or those that are also taking inducer or inhibitor of cytochrome P3A4. So it's been compared clopidogrel. When compared clopidogrel in patient with ACS, ticagrelor produces a greater reduction in primary efficacy endpoints than clopidogrel, and the rate of stroke was similar. And there's no difference in the rate of major bleeding as opposed to Pasugrel that showed higher rate of bleeding when it was compared with clopidogrel. So it's superior to clopidogrel in patients who are to undergo PCI or cardiac surgery, and it's also preferred in high-risk patients. The dosing, as I said, is 180 milligrams followed by 90 milligrams daily, and I've mentioned this. And when you want to combine with aspirin, you have to use a low dose of aspirin at 100 milligrams. Side effects include bleeding, dyspnea, which can occur in up to 50% of patients. She said that it's usually self-limiting and the mechanism is not known. And when you want to do a major surgery, have to stop the Gangrel 5 to 7 days. Dipyridamole is another class of antiplatelets. It's a relatively weak antiplatelet on its own, but when it's combined with aspirin, it can be used for stroke prevention in patients with CIA. The MOA that inhibits phosphodiesterase. Phosphodiesterase block the breakdown of cyclic AMP, and the increased level of cyclic AMP does produce will reduce intracellular calcium and inhibit aggregation. Dipyridamole block the uptake of adenosine by platelets and others. When it's combined with aspirin, was compared with dipyridamole was compared with aspirin or dipyridamole alone or with placebo. The patient with ischemic stroke or TIA, and the combination caused reduction in stroke by 22% compared with aspirin, and by 20.1% compared with dipyridamole alone, meaning that the combination with aspirin has a synergistic effect. And there are many studies that have been done to that effect. In patients with symptomatic coronary artery disease, the combination should not be used for stroke prevention because of insufficient data. Is better in such instance. That is when a patient has good stroke and coronary artery disease, it's better to use clopidogrel and to use combination of dipyridamole and aspirin. Side effects include GI complaint like headache, flushing, dizziness, hypotension, and symptoms subside with continuous use. The glycoprotein 2B3A receptor antagonist, another group of antiplatelets which actually block the outer receptor in the platelets. And as I said earlier, this glycoprotein 2B3A is the outer receptor that actually attaches to the collagen on the damaged endothelium. They are used in patients with ACS, and the three agents in this class is apixaban, eptifibatide, and tirofiban. Apixaban is a FAB fragment of humanized murine antibody that is directed against glycoprotein 2B3A, and it binds to activate the receptor with high affinity and blocks the binding of adhesive molecule. Eptifibatide is a cyclic heptapeptide, while tirofiban is a non-peptidic tyrosine derivative. Let's up to it. Why eptifibatide and tirofiban have a short half-life. Indicated in patients going for PCI, particularly those who have not been treated with ATP receptor antagonists. And tirofiban can be used in high-risk patients with unstable angina. The doses are as written for each of them: apixaban, eptifibatide, and tirofiban. For those with renal disease, the dose of eptifibatide and tirofiban should be reduced. Side effects include bleeding, thrombocytopenia, which is called by antibodies against neuroantigens up to 5%. And it's less common with the other agents. So the thrombocytopenia is commoner with apixaban compared with the other two agents. Other drugs include cangrelor, adenosine analog, and also binds to the P2Y. Is given by IV followed by infusion. So this is a parenteral antiplatelet. To give example of parenteral P2Y12, it is cangrelor. The other P2Y12 inhibitor are oral. And a lot of studies are also been done on the use of cangrelor. Other ones is forapadza. Forapadza is a PR1 antagonist, and the half-life about 200 hours. And it's a lot of trials have been done on it, and it's still being tried. Some of the trials are stopped because of the risk of increased intracranial bleeding. So that leads me to this the few slides I will present to wrap up this presentation. talking about the ESC recommendation to the use of some of the things I've talked about. What is a recommendation, especially what concerns MI, other STEMI or NSTEMI or stable angina. So the recommendations are there. We all know the class 1, class 2 evidence, A, B, or C. So for patients that with patient with ACS, ticagrelor, in addition to aspirin, is recommended regardless of initial treatment strategy. That is, even if you have, for patients that have been treated with clopidogrel before, you can still use ticagrelor. So it's recommended that ticagrelor is recommended on top of aspirin, unless there are contraindications. This is a class 1B recommendation. Also, for patients that you are sure and they are going for PCI, that you have determined their coronary anatomy and you are sure that PCI is what you want to do. Pastoral is recommended the loading dose of 60 milligrams, loading dose, and 10 milligram daily dose in addition to aspirin. For P2Y12 inhibitor naive, end-stage ACS patient, or initially conservatively managed for STEMI, if indication for PCI is established, or in STEMI patient undergoing immediate coronary catheterization unless there's high risk of life-threatening bleeding or other indication. So also, as I said, for those on with in which the coronary anatomy is known, you can give with P2Y12 inhibitor. That is, means that for the PTI, already giving them a loading dose of the antiplatelets. Where those ones that have class 2A recommendation is ticagrelor administration in patient with NSTEMI. In patient with NSTEMI undergoing invasive management, ticagrelor administration or clopidogrel, if ticagrelor is not an option, should be considered as soon as diagnosis is established. And in patient with stable coronary artery disease, the treatment with clopidogrel may be considered if the probability of PCI is high. To note the last one, that in patient with NSTEMI in whom the coronary anatomy is not known, it is not recommended to administer pastoral. I have mentioned that earlier. Now, also other thing I also need to know is that there are recommendations for how to prevent bleeding while patient is on dual antiplatelets. And one of the recommendations is that radial access is preferred over femoral, but it has been found that it reduces bleeding with patient on dual antiplatelets. And also, the dose of the antiplatelet that we use should also be reduced. That will also help to reduce bleeding. And also, can use proton pump inhibitor with the dual antiplatelets. So, also class 1 recommendation. And routine monitoring of platelet function or to adjust antiplatelet activity is not recommended. Now, for patients that are on different, particular antiplatelets, you can switch. Switching is allowed. So in patients with ACS who are previously exposed to clopidogrel, switching from clopidogrel to ticagrelor is recommended early after hospital admission. Only dose of 180 milligram, irrespective of the timing and loading dose of clopidogrel, unless contraindication of ticagrelor exists. Then additional switching between oral P2Y12 inhibitor may be considered in case of side effects or drug intolerance. That's a class 2B recommendation. This is just showing that the only one that has a class 1 recommendation is switching from clopidogrel to ticagrelor. The other switching are class 2B recommendation are depicted by the color of the arrow. This one, we talk about the timing for the dual antiplatelet, depending on what you are doing, either PCI or coronary artery bypass grafting or medical treatment. So for those that are doing PCI, if it's PCI with ACS and the with acute coronary syndrome, and the patient already had stents, either a drug-eluting stent or a bare metal stent, if there's a high if there's no high bleeding risk, so you can do your dual antiplatelet for 12 months and thereafter 6 months, and can also be continued for even more than that. But the one for the first 12 months has a class 1 recommendation, while continuation has a class 2B recommendation. But if there's a high bleeding risk for patient with ACS, you can do your dual antiplatelet for 6 months. That has a class 2 a recommendation. For those ones that has a stable coronary artery disease, who has had a stent, a drug-eluting stent or diameter stent, if there is a high bleeding risk, you can do 2 antiplatelets for just 3 months. That's a class 2B recommendation. Whereas if there's no high bleeding risk, you can do 2 antiplatelets for first 6 months, which can be extended after the first 6 months. So the first 6 months is a class 1A. So this, the same thing goes for the those one that has scabbard in the middle, coronary artery bypass grafting. If they come in ACS and they have a high bleeding risk, so you do 2 antiplatelets for the first 12 months. That's a class 1A recommendation. After which you cannot continue after the 12 months with either aspirin and ticagrelor or aspirin and pasogrel. But the recommendation after the first 12 months is lesser compared with the recommendation for the first 12 months. For those ones that you are doing medical therapy for, if the ACS with medical therapy, which is on this corner, if they have a high bleeding risk, if there's no high bleeding risk, you do their 2 antiplatelets for 12 months, after which you want to continue. The first 12 months has a class 1 recommendation, where the extended one has a class 2B recommendation. You note that, as I said earlier, this one you want to avoid passive because passive have not been shown, have not been recommended for those one that want to do medical treatment for. So this is dual antiplatelet therapy duration and related stent choices in patient with stable coronary artery disease, PCI. So, and the two that has a class 1 recommendation is patient with stable coronary artery disease that you are treating with coronary stent implantation. That is recommended for 6 months, irrespective of the type of stent used. Whereas for irrespective of the intended DAPT duration, drug-eluting stent is preferred treatment option. Those are the two that have class 1 recommendation. So, dual antiplatelet therapy duration in patient with high coronary syndrome, we treated with PCI. For the one that we do with PCI, patient with PCI with coronary stent implantation, DAPT, that is dual antiplatelet composing of P2I2 inhibitor and aspirin are
Is it my network? The slide has disappeared though.
Yeah, I think we've lost Dr. Ojo. Network. Let's give him a few minutes and see if he'll be able to join again.
sorry, am I still audible?
You're audible now. You went off for a while.
Yes, I went. Yes, I went. I went the network. Please, am I audible now?
Yes, you can go ahead.
Okay, thank you. So for I was talking about coronary artery bypass grafting. Those patients that have been started on aspirin initially before CABG. So recommendation that we should continue the aspirin, even continue the aspirin. So for inpatients who on aspirin who need to undergo non-emergent cardiac surgery, it is recommended to continue aspirin at a low daily regimen throughout the preoperative period. I think I've mentioned that. In patients with dual antiplatelets, after coronary stent implantation, who subsequently undergo cardiac surgery, it is recommended to continue to resume P2Y12 inhibitor therapy post-operatively as soon as it deemed safe, so that continues until the patient with ACS treated with dual antiplatelet undergoing coronary artery bypass grafting and not requiring long-term oral anticoagulant therapy, resumption of P2Y12 inhibitor therapy as soon as deemed safe after surgery, and continuation up to 12 months is recommended. All these receive a class 1C recommendation. So, am I still audible?
Yeah, you can go ahead. It's a little bit cracky.
Please, am I still audible?
Breaking
Yes,
it,
Ojo,
but you
just
can
like
go
you're
ahead.
going on and off.
Mm.
Hello, am I audible?
Hey.
You are audible, Baba.
Am I audible?
You are audible, sir.
It looks like he can't hear us, so.
Am I audible?
Mm.
Okay, sorry. Sorry.
Wow.
Okay, so for patients for medical therapy, it is recommended that do antiplatelets comprising of P2Y12 inhibitor with either ticagrelor or clopidogrel be continue for 12 months. Ticagrelor is recommended over clopidogrel unless there is bleeding risk outweighs the potential ischemic benefits. Those are class 1 recommendation. And as I said earlier, we should know that Pasugrel is not recommended for medically managed ACS patients. Am I audible?
Yeah, go ahead. We're getting you. How
Okay,
many
thank you.
slides do you have left?
No, I'm almost done. It's not much again.
Okay. Okay.
Not that my screen is not moving again. Okay, let me just use let me use the one on my phone. Dr. Conte,
Yes, please.
please can you help me share my screen from that place I stopped? My screen is not moving. I don't know why. Let me just finish
Okay.
so that I can just finish. Yes, from that last slide I stopped.
Is it this one? No.
No. No,
Is it?
back. Yeah, yes. Okay. So I was here. So next one after this. Next one. Okay, so thank you. So this one is for those one that have indication for oral anticoagulation. I know yesterday we talked about anticoagulation. There are some patients that will be on antiplatelets, and we also need to be on anticoagulant. Either they have atrial fibrillation or they have another reason to be on anticoagulant. So what we should know in those kind of situations is that the first thing we need to do is to um, assess the patient for bleeding risk, and the ischemic risk. So, if the ischemic risk supersede that of bleeding, you can do the triple regimen, the dual antiplatelet and anticoagulant for 1 month. For 1 month, that is then which can also be extended up to, that's a class 2 recommendation. It can also be extended up to 6 months. And after which you now change to dual after 6 months. That is either clopidogrel and anticoagulant or anticoagulant. After 12 months, you now go to anticoagulant alone. But for those one that has a higher bleeding risk, you can do either just do dual, that is clopidogrel and oral anticoagulant for 12 months, after which you go to oral anticoagulant alone, or you do triple therapy for 1 month, and go after 1 month, go to dual, that is clopidogrel and anticoagulant, or antiplatelet and anticoagulant for up to 12 months. Then after that, go to anticoagulant alone. So it depends on which of these risks supersede the other, either the ischemic risk or the bleeding risk. Next slide, please. So how do you reduce bleeding in patients with triple therapy? These are the various things that we can do. I've mentioned the first point: assess the ischemic and bleeding risk. Keep the triple duration as short as possible. Use non-vitamin K instead of vitamin K, and also target INR. Also use a low dose of aspirin and PPI. Next slide. Next slide. Okay, the high risk features. These are the things I want to consider for high risk features of recurrent ischemic events. Patient with prior thrombosis, patient that on stenting, patient that has CKD, patient that has at least 3 stents implanted, patient that had 3 lesions treated. When you total length of stent is more than 60 millimeters, these are features of high risk of recurrent ischemic event. Next slide. Next slide. The unfavorable patient profile for combination of anticoagulant and antiplatelet. So assessing patients' individual risk is very important. And by the time we see each of these unfavorable conditions, we want to shorten the duration of the triple regimen or use a double regimen. So we can just go through this. Let's go to the next slide. Now, for dual antiplatelet therapy duration in patients who are indication for oral anticoagulation. So the only one that received a class 1 recommendation there is to administer peri-procedural aspirin and clopidogrel in patients undergoing coronary stent implantation. And a patient treated with coronary stent implantation, triple therapy with aspirin, clopidogrel, and oral anticoagulant should be considered for 1 month, irrespective of the type of stent used. I think I have mentioned this earlier. Let's go to the next slide. Now, for patients undergoing elective non-cardiac surgery, this is very important because for patients that are being maybe has a stent in place and need another surgery, elective surgery, what should we do in that situation, non-cardiac surgery? It's recommended that continue preoperatively if the bleeding risk allows, and to resume the recommended antiplatelet therapy as soon as possible postoperatively. After coronary stent implantation, that's a class 1B recommendation. After coronary stent implantation, elective surgery requiring discontinuation of the PTY12 inhibitor should be considered after 1 month, irrespective of the stent type. So what this one is just saying is that for patient that has a stent implanted, you should avoid elective surgery within the first 1 month of the stent, because that patient must be on the dual antiplatelets because you just newly implanted stent. So that patient must be on. So if it's elective surgery, that one can be postponed after 1 month. So for those one that now has maybe a difficult situation in which you have to do the surgery, you can use other agents like intravenous antiplatelets just in that window period. That's what this recommendation is saying. Next slide. Okay, this is almost the last one. So this is just to bring all the recommendation together. Recommendation for PTY12 inhibitor selection and timing, measure to minimize bleeding, which I've talked about, switching, which I've talked about, dual antiplatelet duration in patient with acute coronary syndrome with PCI, then for patients that or medical treatment, or for patients that are preparing for a non-cardiac surgery. And it's also important to know that the similar type and duration of dual antiplatelets are recommended in both male and female patients. Next slide, please. These are my references. Thank you very much for the cooperation and the possibility of doing this presentation today. Thank you.
Yes,
I'm open to any
very
questions.
much. Thank you very much, Dr. Ojo. At least despite the unstable network, we are still able to listen to your presentation. Thank you so much for a detailed presentation. Even myself, I'm a bit tired, but all the same, I'll open the floor for questions. Questions and comments, please. I hope everybody else is not asleep.
Seems as people are sleeping.
Chief Okopi.
Excellent presentation, I must say. Conte, I'm so grateful for staying. I'm so sorry I left. I had to submit a detailed report on something for the state, the Plateau State where I work as the chairman, vice chairman. So it took my time. I had to type a lot. So I had to go off. So I'm so grateful for coordinating. You've been quite excellent. Thank you so much, sir. Akiro Ojo, thank you so much for the resilience to take this presentation despite the network challenge.
Thank you, sir.
It seems most persons are quite tired, but I think take 1 or 2 exam experience and contributions. If the candidates are not asking, let me call Adeyanju. Adeyanju, do you have anything to say? Okay, I think Adeyanju is not around. What about
Hello,
Siri?
Chief.
Okay, yeah.
Oh, sorry, I was trying to unmute.
Okay.
Yes, thank you so much, Dr. Ojo, for an excellent presentation. Well, the place that this topic came out during our exam was during the OSCE, I should think. There was a part of OSCE that they asked us about medications indirectly in the management of a patient that had something like a coronary artery disease, and they were asking about the specific mechanism of action of the drugs that we give to the patient. So I think this is where this particular topic came up, because the exam actually asked me directly, okay, would I consider antiplatelets? Which one? What's the mechanism of action? So I think that we should take this case actually very important. We should know the specific mechanism of action, and then we should be able to differentiate between the short-term and the long-term one. Maybe it's the prasugrel or the efotibide or whichever one, we should be able to differentiate to. In our MCQ, I can't recollect this really coming out, but it came out in the past. So it's something that we just try and know the mechanism of action. It's very important. I think that's the experience that I can remember. Thank you very much, and well done, everyone.
Thank you. Dr. Kabir, it's long. Thank you. Dr. Sirius.
Thank you very much, Chief.
Yes, sir.
Thank you, Ojo. It was a good presentation. Thank you.
Dr. Alex, any contribution? Okay. So, Dr. Ayodeji, any contribution you have before we
A brilliant presentation, Dr. Ojo. It was a great one. It's just to know that the clopidogrel and the prasugrel, and both of them, they're pro-drug. They're pro-drug in the MOA. And then the factors who can also be responsible for suboptimal clopidogrel response. Talked about the genetic factors, cellular factors, and clinical factors. That's all. They're talking about the genetic factors, the polymorphism, the CYP, GP1A, P2Y. I mean, when you have a polymorphism in the P2YA or CYP, those are the genetic factors. And then when you talk about the cellular factors, accelerated platelet turnover, increased ADP exposure, upregulation of the P2Y12, and upregulation of there are two receptors apart from the P2Y12, but you have more of the P2Y. There's also P2Y1. We need to know. Thank you.
Wow.
Thank you.
Wow. Thank you so much. Thank you so much. Also, I just want to say thank you to Dr. George Ofosu for always available to keep records. We're so grateful. Dr. Conte, thank you so much for your leadership. In the absence of any other comments, queries, I hand over the class to you. Thank you, sir.
Yes, thank you very much, Chiefs, and thank you, everyone. So we are almost at the tail end of Prof's book. So tomorrow we should finish, God willing, and then we'll take one more curriculum topic tomorrow. Florence, do you have any last words?
Okay, I just want to specially say thank you to all the presenters, Chineme, Mba, Itubi, Maduka, Finene, and Onyibuizi. Let's just keep on pushing. We can all do it together and to come out successful. Thank you. Thank you so much. All right, good night, everyone.
And please, those who are taking the remaining questions, so tomorrow we must finish. So there will be no postponement tomorrow, please. So thank you, everyone. Have a restful night.
Thank you. Good night, everyone.